All right, welcome everyone to this Diaceutics Lab Talk. Today our topic is classification of myeloid neoplasms, navigating ICC and WHO-HAEM5 differences. And our speaker is Dr. Sonam Prakash from UCSF. So here's a quick look at today's agenda. My name's Ian Moore. I'm a network development manager with Diaceutics. So I'm going to provide a short background about Diaceutics as a whole, as well as DXRX, which is our precision medicine platform for labs. I'll turn it over to Dr. Prakash for a presentation. At the end, we'll have some time for audience Q&A. At any point during the presentation, you can type your questions. There should be a box below your screen, where you can enter your questions that we'll answer. So Diaceutics, we are an end-to-end services provider and data analytics company, and we're specialized in precision medicine. Our mission is better testing, better treatment, and we're building towards a future where the lab testing ecosystem allows all patients to receive the right testing and the right treatment at the right time. So we believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in almost 100 disease pathways. We've worked with 36 of the top 40 pharma clients to bring precision medicines to market. And we also have a global presence, which enables a sharing across a knowledge sharing across a vast range of topics. So DXRX, our precision medicine platform, is free for everyone to register. And with a membership to DXRX, you receive free access to things like easy to navigate lab map US claims data dashboards. For example, we have NGS and IHC testing right here, but we also have more dashboards on there as well. You'll receive a curated feed of CDX and precision medicine news and resources. You can receive access to Diaceutics and pharma-sponsored collaborations for both labs and pathologists, and then also additional lab-focused webinars like the one that you are tuned into right now. So we encourage everyone to sign up. There should be a box off to the left side of the screen where you can sign up or book a meeting with me to learn more about what we do at Diaceutics and a DXRX membership. So I will now take the time to introduce Dr. Prakash. So Dr. Prakash is a clinical professor in the Division of Hematopathology at University of California, San Francisco. After completing her hematopathology fellowship at NIH and NCI, she worked as an academic hematopathologist at University of Pittsburgh Medical Center and Weill Cornell Medical Center prior to joining UCSF in 2013. Her clinical expertise is in the diagnosis of myeloid and lymphoid neoplasms with a particular interest in chronic myeloid neoplasms. She's authored many peer-reviewed publications and book chapters on diagnosing myeloid neoplasms, including chapters in the International Consensus Classification of Myeloid and Lymphoid Neoplasms. She's actively involved in hematopathology education and has served on committees for Society for Hematopathology, United States and Canadian Academy of Pathology, the American Society for Clinical Pathology, and California Society of Pathologists. So with that, I will turn it over to you, Dr. Prakash. We're excited for the presentation, and thanks for joining us.
Sorry. Thank you so much, Ian, for the introduction, and thank you all for attending this webinar. So the topic for today's webinar is a little complex and nuanced topic. Classification of myeloid neoplasms have become very complex, and today in this webinar, I will present a hematopathologist's perspective in how we diagnose these myeloid neoplasms using the International Consensus Classification and the WHO classification based on the 5th edition. So I will start by providing a very brief historical perspective of the classification of myeloid neoplasms, and then we will talk about the current classification systems of myeloid neoplasms, the International Consensus Classification, and the World Health Organization Classification of Hematolymphoid Tumors, the 5th edition. We'll talk about similarities and differences between the two, and also look at a few examples to see how we use these two classifications for arriving at diagnoses. So in this webinar, I will only talk about adult myeloid neoplasms and pretty much focus on acute myeloid leukemias and myelodysplastic syndromes, because these are the two categories where we encounter challenges based on these two classifications. I will very briefly touch upon myelodysplastic/myeloproliferative neoplasms and myeloproliferative neoplasms. I will not discuss pediatric or germline neoplasms in the interest of time. In the end, we will talk about the implications of these two classifications and practical approach for navigating the differences between the two. And then, as Ian mentioned, we will have time for questions and answers after that. So when we look at the classification of myeloid neoplasms, they have really evolved over time. And the first consensus classification that was published was in 1976, which was the French-American-British classification, based entirely on morphology and cytochemistry, because that's what was available back then. In that classification, based on morphology, if there were myeloid blasts for AML, a blast threshold of 30% was established. And then 25 years later, the first WHO classification was published that included not just morphology, but also immunophenotype, genetics, and clinical features for classification. At that time, we lowered the blast threshold to 20%, and also it was during this classification that we recognized that a subset of AML have recurrent genetic abnormalities. The next classification was 7 years later, which built on the prior classification, but now added molecular features for classifying these neoplasms, and entities such as AML with mutated NPM1 and AML with CBPA mutations were introduced. Also, in the world of chronic myeloid neoplasms, some of the genetic abnormalities were added to diagnose and classify these entities, such as JAK2 and MPL driver mutations in myeloproliferative neoplasms. So the next classification, which was called the revision of the fourth edition, that was published, or actually it was finalized in 2016, published in 2017. This further refined the diagnostic criteria based largely on the advanced information that we had on the genetics of hematopoietic neoplasms. As technology advanced and it became more widely available, we had a better understanding of the genetic features of hematopoietic neoplasms. And pretty much in this revised classification, most of the entities, we refined the diagnostic criteria. So one thing is that the whole purpose of classification systems is to standardize diagnosis, which in turn standardizes treatment and development of clinical trials. So until 2016, 2017, we all had one classification to follow, which made things easy, or easier than what it is now. In 2022, two classifications were published, the International Consensus Classification and the WHO 5th edition. Both of them are derived from the prior WHO classification, the 2016 classification. So they have a lot of similarities, but they also have some differences. And one thing to note is, as we learn more, as you can see, classifications evolve, they change. The more we know, the more we add to our classifications. So one question that comes up, well, do we really need to know about classifications? Why can't we just use one or the other? And as I mentioned, classifications inform risk stratification, which in turn lead to treatment decisions. Different clinicians or clinical trials may use one or the other classification, so it is really important for both pathologists and clinicians to be familiar with both classifications that we have. Since we all are very familiar with using the WHO classification, one of the things as well, we've always used WHO, why can't we just keep using just the WHO classification? One thing to realize is that treatment recommendations may not always be based on WHO. The 2022 ELN treatment recommendations for AML are actually based on ICC, and many clinical trials, or I should say most clinical trials, and also a lot of clinicians use the ELN recommendations for treatment. So it is really important for all of us in the world of HAEMPath to understand both classifications. While we worry so much, one thing to realize is that the two classifications are largely similar, but they do have some significant differences. So the important thing is to know what are the significant differences between the two classifications, and that's something that we will try to achieve in this webinar today. So both ICC and the WHO 5th edition classifications, they are based on advancements in the understanding of biology and genetics of hematopoietic neoplasms. Based on our experience using the prior WHO 2016 classification, many entities that we included in the WHO needed to be modified. Some we eliminated, new entities were added, and also these classifications are based on our experience from the results of clinical trials. Both have the same objectives: to facilitate precision diagnosis and prognostication, which in turn improves treatment options, and also to allow the design of innovative clinical trials. When we have detailed genetic and molecular profiling for these different neoplasms, that enables more precise stratification of patients for clinical trials. And that is one of the goals of both these classifications. And as I mentioned, the two classifications are largely similar, and just the broad similarities. Both emphasize genetics over morphology, although they do include morphology, but now there is a much greater emphasis on genetics. And both these classifications now have expanded the list of entities that are defined by genetic abnormalities. Both have refined the criteria for diagnosis, even though most of the entities are similar to what we had in the WHO 2016 classification, but now both have more refined diagnostic criteria. And both require integration of morphology with genetics and clinical findings. But there are significant differences. There are some entities that are defined by genetic findings only in one classification, but the other classification requires genetic findings and some morphologic findings. There is a difference in blast threshold for certain entities in the two classifications. There are some entities that are included in one classification only and not the other. Even when the two classifications use the same genetic abnormalities, let's say mutations in the same genes, the variant allele frequency thresholds that are used are different. And for some entities, the criteria that we use for diagnosis, they are fairly different. As a result of all these differences in the two classifications, we end up with cases where the diagnoses are different, and that in turn affects treatment decisions and also patients' eligibility for clinical trials. So next, I want to focus on specific groups of myeloid neoplasms and then see how the two classifications are similar or dissimilar. So we'll start with myelodysplastic syndromes, a term that is still retained by ICC, who calls them myelodysplastic neoplasms, but it's the same thing. How are the two classifications similar for MDS? They both have similar thresholds for cytopenia and dysplasia. They both use similar broad categories for subclassification, namely presence of certain genetic abnormalities, increased blast percentage, and cases that don't have increased blast percentage, they are classified based on their morphologic characteristics. Both ICC and WHO follow a hierarchical classification for MDS, and we'll look at all these things in a little more detail in the next few slides. So I want to start with MDS based on increased blast percentage. So when we say increased blast percentage, what do we mean? The thresholds we use are 5% or more blasts in the bone marrow or 2% or more blasts in the peripheral blood. While both classifications have categories of MDS with increased blasts, they are classified differently. The current WHO classification, the 5th edition, how it classifies MDS with increased blast is similar to what we had in the WHO 2016 classification. We classify them as MDS with increased blasts 1 and increased blasts 2. And also, the current WHO classification has added another entity, MDS with increased blasts and fibrosis. This includes cases of MDS that encompass both increased blast 1 and increased blasts 2, but also have significant fibrosis. In ICC, how we classify MDS with increased blast has changed significantly. There is one category of MDS with excess blasts for cases where blasts have 5 to 9% in the bone marrow and 2 to 9% in the peripheral blood, or if these have hour odds. Cases of MDS that have 10 to 19% blasts in the bone marrow or peripheral blood by ICC, they are now called MDS/AML. So this category does not exist in the WHO 5th edition. So MDS/AML in ICC corresponds to MDS increased blasts in the WHO 5th edition. ICC does not have an equivalent category for MDS with increased blasts and fibrosis. So this particular group of MDS AML and corresponding MDS increased blast 2 in the WHO 5th edition, that creates diagnostic challenges. And let's see a little bit more about these two and what the significance is. ICC uses the term MDS AML, as I mentioned, for cases with 10 to 19% blast in bone marrow or peripheral blood. And the reasoning is that these cases really lie on the border between MDS and AML in terms of their biology or prognosis. So therefore, the nomenclature was changed to reflect that. These cases are subclassified using the same criteria as AML, including risk stratification. So in ICC, if you have 10% or more blasts in a case of MDS, when we use the term MDS AML, we're pretty much, when we are looking at the risk stratification or further subclassification, we're pretty much following what we would for AML. And the rationale for this change is that these patients who have 10 to 19% blasts should be eligible for both MDS and AML therapy or clinical trials. These cases would fall under MDS with increased blast 2 based on the WHO classification. And for these cases, the risk stratification is similar to what we would use for the rest of MDS cases, which is our International Prognostic Scoring System. WHO also states that these cases can be treated either as MDS or AML, but did not want to use the terminology of AML to avoid overtreatment of these cases. So as you can see, just by this different nomenclature, the diagnosis can be different and they can result in potentially different treatments because you are treating one group, if you follow the ICC classification, as more like AML, and the other one still retains the MDS nomenclature. Next, I want to talk about the category of MDS with defined genetic abnormalities. So both classifications have this category. Both classifications use the same genetic abnormalities for classifying an MDS in this category, namely TP53 mutation, deletion 5q, SF3B1 mutation. However, there are slight differences. For cases of MDS with deletion 5q and SF3B1 mutation, there are minor differences related to the requirement of dysplasia for deletion 5q in WHO, not in ICC. The variant allele frequency threshold for SF3B1 mutation is different in the two classifications, but really clinically, they don't create that much of a challenge and they're not that different from a clinical perspective. The bigger issue is cases with TP53 mutation, and we'll look at this in a little more detailed way. So ICC uses the term MDS with mutated TP53 for cases of MDS that have less than 10% blasts. Although they just say MDS with mutated TP53, they're essentially, for these cases, they are implying biallelic TP53 mutations. WHO calls them MDS with biallelic TP53 inactivation. How can you get to this diagnosis? The criteria are similar in the two classifications, yet have some differences. First way is if you have 2 or more TP53 mutations, and that's included in both. However, ICC requires a variant allele frequency threshold of 10% for each of the TP53 mutations. WHO, on the other hand, does not have a VAF threshold for TP53 mutations. The next is if you have just a single TP53 mutation, you can still get to this diagnosis if there is deletion in 17p or loss of heterozygosity at the 17p TP53 locus, which is also included in the WHO classification. In addition, ICC also includes complex karyotype for these cases because per ICC, complex karyotype can be used as presumptive evidence of a second TP53 hit when you only have one TP53 mutation. However, WHO specifically requires you to demonstrate deletion 17p or loss of heterozygosity at 17p. Both classifications include that if you have a single TP53 mutation with a high VAF, you can still call the case MDS with mutated TP53. The VAFs are slightly different. ICC says more than 50%, WHO says more than 49%, but that's really not that significant. One more thing to point out. In ICC, when we say MDS with mutated TP53 or biallelic TP53, as I mentioned, that's for cases with blasts less than 10%. If a case of MDS is 10 to 19% blast, even a single TP53 mutation with a VAF of more than 10% qualifies for a diagnosis of MDS AML with TP53. Whereas in the WHO classification, it doesn't matter whether it is MDS with increased blast 1 or increased blast 2, you have to have biallelic TP53 inactivation. The significance of these cases of MDS with biallelic TP53 inactivation is that they have a very poor prognosis irrespective of blast count, and they are really resistant to therapy. And the differences in our diagnostic criteria are mainly related to complex karyotype, TP53 mutation variant allele frequency threshold can result in discordant diagnosis by WHO and ICC and impact treatment. Let's see this with an example. So this is an 88-year-old patient with pancytopenia and 8% circulating blasts. The bone marrow is hypercellular, trilineage dysplasia, and has 14% blasts. Cytogenetics showed a complex karyotype, including deletion 5q. Next generation sequencing identified mutations in several genes, including TP53 with a VAF of 32.6%. So how would we classify these cases? So if you look at the ICC classification, the presence of more than 10% blasts would qualify this case for MDS AML. In cases of MDS AML, even if you have a single TP53 mutation, that's enough to make a diagnosis of MDS AML with mutated TP53. When you look at the WHO classification, because the blasts are more than 10% in the marrow, more than 5% in peripheral blood, by WHO this would be called MDS with increased blasts 2. Now, would this meet criteria for MDS with biallelic TP53? It won't by the WHO classification because there is only one TP53 mutation. In that instance, WHO does not consider complex karyotype as presumptive evidence of second hit. It requires us to show that there is deletion 17p or loss of heterozygosity at 17p TP53 locus. In this case, on cytogenetics, we did not see deletion 17p. So by WHO, this case stays as MDS with increased blasts 2. And if we don't see anything else in the diagnostic line, it really doesn't convey the poor prognosis that TP53 has in these cases. Another hypothetical situation, let's say this case had less than 10% blasts. By ICC, would it meet criteria for biallelic TP53? The answer is yes, because we have a single mutation with a VAF over 10%, and there is complex karyotype. So by ICC, it would still connote a very poor prognosis, which the WHO classification may not. Does it impact treatment? Well, while both are poor prognosis, in this case it didn't because patient declined treatment. But if the patient were to get treated, there may have been differences in how they would be treated, depending on which classification you follow. The last category of MDS is based on morphology when the blasts are not increased. For this category, the two classifications are largely similar. WHO calls them MDS with low blasts, but includes two specific categories based on their therapeutic relevance. One is hypoplastic MDS. These are cases that are hypocellular, but respond well to immunosuppressive agents. And the other one is MDS with low blasts and ring sideroblasts. These are cases that have 15% or more ring sideroblasts that we can identify with an ion stain. The importance of these is that these cases are also eligible for treatments that patients that have MDS with SF3B1 mutations would be. ICC just puts them in the category of MDS NOS and does want us to specify whether the dysplasia is in one lineage or more than one lineage. But in clinical practice, really, these don't create that much of a challenge. And as I mentioned, both ICC and WHO follow a hierarchical classification for MDS, starting with MDS with biallelic TP53 inactivation based on its very poor prognosis. Next, we look at blasts if they are increased. ICC has a category of MDS excess blasts. WHO says MDS increased blasts and divides them into 1 to 2 based on the blast percentage. And again, to note that MDS AML is this distinct category now under ICC, which is classified similar to AML, and these are cases with 10 to 19% blasts. They are not really included when we talk about MDS. They're really not included in the broad MDS umbrella in ICC. The next category is MDS with deletion 5q based on its response to treatment with lenalidomide, followed by MDS with mutated SF3B1, given its response or eligibility of these patients for treatment with luspatercept. And then the last category, MDS NOS by ICC and low blasts or hypoplastic MDS or ring sideroblast, depending on the morphology based on the WHO classification. Okay, so next we will talk about the two classifications in acute myeloid leukemia. Let's look at the similarities between ICC and WHO. Both subclassify AML into similar broad categories recognizing similar features that include AML with recurrent genetic abnormalities, AML with myelodysplasia-related findings, AML occurring in specific settings as post-therapy, AMLs associated with germline mutations, and then just AML based on morphology. Now, when we look at these specific categories, so if we look at AML defined by recurrent genetic abnormalities, this really busy slide is just to emphasize the number of entities that have been added to this list. The entities are similar in both classifications. And if we look at it previously, we had only 3 entities that were included into the WHO 2016 that did not require a 20% blast threshold for diagnosis. But now both classifications have so many more abnormalities that have been added. So looking specifically at this category, looking at the similarities between ICC and the WHO classification, both these classifications have expanded the list of rearrangements that we saw. They have included rearrangements of KMT2A, MECOM, NUP98 to the list. One thing to note is that these rearrangements can be missed by conventional karyotype. They can be cryptic. So it is important for us to make sure that we have appropriate testing to pick these up. Both have included a category of AML with other rare recurring translocations, and both have AML defined by gene mutations, and the genes that are included are NPM1 and CBPA. But once again, there are differences, and the differences are significant. The most important difference is the blast threshold. The WHO classification, the current WHO classification, does not require a blast threshold for AML with recurrent genetic abnormalities, except in AML with BCR-ABL rearrangements, AML with CBPA mutation, and AML with other rare recurring translocations. However, ICC requires a blast threshold of 10% or more, except for AML with BCR-ABL1. Both classifications have this 20% blast threshold for AML with BCR-ABL1 so that it doesn't overlap with CML. But not having a blast threshold in WHO and having a blast threshold in ICC does create diagnostic challenges. The other difference is AML with mutated CBPA. This has a favorable prognosis. ICC has more stringent requirements. For this category, they require an in-frame BZIP CBPA mutation. And if you look at the gene for CBPA, the green part, that's the BZIP domain, and ICC requires an in-frame mutation in that BZIP domain. Per WHO, if you have 2 mutations, doesn't matter where they are, or any mutation in the BZIP domain doesn't have to be in-frame, qualifies a case for AML with mutated CBPA. Given these differences, there are cases where they pose diagnostic challenges. A case may be classified as AML in one and not the other. Let's look at an example. This is a 46-year-old patient with pancytopenia and fatigue for a few months. Peripheral blood showed pancytopenia with no circulating blasts. The marrow was markedly hypocellular, and I showed an H&E picture there, cellularity of 5 to 10%. There were dysplastic megakaryocytes by CD61, and blasts were mildly increased, and that's a CD34 stain showing mildly increased blasts that we estimated as approximately 5%. Cytogenetics showed an abnormal karyotype, and FISH was positive for MECOM rearrangement. Next generation sequencing identified mutations in some genes. So now, as I mentioned, MECOM rearrangement is included in the list of abnormalities in AML with recurrent genetic abnormalities. If we look at this case from an ICC perspective, even though we have a MECOM rearrangement, we don't have 10% blasts. So this case is still classified as MDS with excess blasts because blasts are 5% based on ICC. But based on who? This case is classified as AML with MECOM rearrangement. And then now there's a big difference in how the two classifications will diagnose this case. So what happened to this case in terms of treatment? So when we discussed this case with the clinician, well, they felt that given the marrow is hypocellular, blasts are not that increased, they decided to treat the patient as MDS. The patient was treated with supportive care for 3 months, and during this time, he did not show an increase in blast beyond the 10% threshold. Given the MECOM rearrangement, the patient did receive a stem cell transplant, but he relapsed 5 months later with more than 20% blasts and is currently on azacitidine and venetoclax. You could argue, should he have been treated with AML to begin with? Was MDS treatment the right treatment? It is hard to say. But this is really a very good example of how the two classifications can result in very different diagnoses with significant treatment implications. The next entity that creates challenges is AML with mutated TP53. This is recognized as an entity in ICC only, but not in the WHO classification. To make this diagnosis, we need 20% or more blasts for a diagnosis of AML and at least a single somatic mutation in TP53 with a variant allele frequency of 10% or more. And again, to mention that in ICC, cases that are called MDS AML with 10 to 19% blasts, even in those cases, if there is a single TP53 mutation with a VAF more than 10%, we would classify that MDS AML with mutated TP53 and kind of has a similar prognostic and therapeutic relevance as AML with mutated TP53. These cases often have a complex karyotype. They are commonly seen in therapy-related settings. They have a very poor prognosis and are resistant to chemotherapy, at least the conventional chemotherapy. This entity does not exist in the WHO classification. So for these cases, if we were to classify them using our WHO 5th edition, most of these would fall under the category of AML with myelodysplasia-related changes given the presence of complex karyotype. So let's look at a little bit more at this entity of AML myelodysplasia-related. WHO classification has this broad umbrella called AML myelodysplasia-related. That's a specific category. And you can get to the diagnosis if a case of AML has MDS-associated cytogenetic or molecular abnormalities, or if this AML arises in a patient with a prior history of MDS or MDS-MPN. ICC does not have this broad umbrella category, but instead separates them out into distinct categories, distinct diagnoses, as AML with myelodysplasia-related gene mutations and AML with myelodysplasia-related cytogenetic abnormalities. Cases that occur in patients with a prior history of MDS or MDS-MPN, in ICC, we just add a qualifier after classifying the case based on morphology and genetics. Just the prior history of MDS or MDS-MPN is not used to define this category of AML related to myelodysplasia in ICC. Both ICC and WHO have excluded cases based solely on morphologic multilineage dysplasia. They require one to have these MDS-associated abnormalities. And in WHO, also prior history would qualify one for this diagnosis. So when we look at the MDS-associated cytogenetic and molecular abnormalities in the two classifications, they are largely similar. The molecular abnormalities that are included in both ICC and WHO, they're similar, except ICC also includes mutations in RUNX1, which WHO doesn't. When we look at the cytogenetic abnormalities, again, they are largely similar with minor differences. In ICC, trisomy 8 and deletion 20q are also included as MDS-associated cytogenetic abnormalities. WHO does not include those two, but instead includes deletion 11q, monosomy 13, deletion 13q. So you can see that, for the most part, the diagnoses are concordant, but there are rare instances where presence or absence of some abnormalities may change the diagnosis. What is the significance of AML myelodysplasia related? These cases are included in the adverse risk category by ELN, and having this diagnosis impacts choice of treatment. AML myelodysplasia related are approved for treatment with CPX 351, and also these patients are eligible for certain clinical trials. So rendering this diagnosis is important. Okay, so now, given that there are differences in the two classifications, let's look at an example where we end up having a discordant diagnosis using ICC or WHO. So this is a 70-year-old patient with pancytopenia. Peripheral blood showed pancytopenia with about 5% blasts. The bone marrow showed 32% blasts, which were myeloid by flow immunophenotyping. We have a diagnosis of AML. Cytogenetics showed complex carrier type, including deletion 5q, 7q, deletion 17p, and NGS identified a TP53 mutation with a VAF of 18.7%. And then I showed a picture of CD34, also highlighting the increased blasts. So now, how do we diagnose this case? Per ICC, we have a diagnosis of AML based on 32% blasts that are myeloid, and we have a single TP53 mutation with a VAF of 18.7%. So this is AML with mutated TP53. WHO does not have this category, so this would be classified as AML myelodysplasia related based on the complex carrier type. Does it matter from a treatment perspective? Well, if you remember in the previous slide, I had mentioned AML myelodysplasia related, they are eligible for certain treatment, like with CPX 351. AML with mutated TP53 usually does not respond to that therapy. And if you just look at the diagnostic line alone as AML myelodysplasia related, it really does not convey the resistance to therapy, which AML with mutated TP53 would. So here, what happened in this patient? So usually cases of AML with mutated TP53, the intent is to take them to transplant as soon as possible. This patient was not a transplant candidate, and since this would not have good response to therapy, the decision was made to put the patient just on palliative low-intensity therapy. So again, you can see how different diagnostic criteria in the two classification systems result in different diagnoses that can impact treatment decisions. Both ICC and WHO follow a hierarchical classification of AML, and I'll start with the ICC classification. We start with AML with defining recurrent genetic abnormalities with a blast threshold of 10% or more. If you don't have that, next is AML with mutated TP53. If you don't have that, then you look for AML with myelodysplasia-related gene mutations. After that is AML with myelodysplasia-related cytogenetic abnormalities, and then AML NOS. ICC adds these diagnostic qualifiers, therapy-related or arising from prior MDS or MDS-MPN or associated with germline mutations, to whatever is the diagnosis based on morphology and genetics. And again, one more thing, to reiterate, in ICC, cases with 10 to 19% blasts that are called MDS-AML follow a similar hierarchical classification in the ICC. WHO has, again, a similar hierarchical classification, again starting with AML with defining recurrent genetic abnormalities, but who does not have a blast threshold for this entity. Since we don't have this category of AML with mutated TP53 doesn't exist in WHO combines AML with myelodysplasia-related gene mutations and cytogenetic abnormalities into one category as AML myelodysplasia-related. Also includes cases arising from in patients with a prior history of MDS or MDS-MPN. And then what ICC uses as diagnostic qualifiers, who just puts them as secondary AML and then specifying like why is it is secondary to what. And then there is AML based on differentiation, which kind of correlates with AML NOS in the ICC classification. So just to summarize the major differences in MDS and AML between the two classifications, and I think that is really like the most significant difference in the between ICC and WHO 5th edition for all myeloid neoplasms is this category of MDS and AML. So the first thing is MDS AML, this category is included in ICC for cases with 10 to 19% blast, not included in WHO as a separate category. WHO still has these as MDS with increased blast too. The next is MDS with biallelic TP53 inactivation. ICC uses different diagnostic criteria. It requires a VAF threshold of 10% for TP53 mutations, includes complex karyotype. WHO does not have a VAF threshold and does not include complex karyotype, requires specific demonstration of deletion 17p or loss of heterozygosity for TP53. A very big category of AML with mutated TP53, separate category in ICC, not recognized in the WHO classification. And then for AML with recurrent genetic abnormalities, difference blast threshold 10% or more in ICC, no blast threshold in the WHO 5th edition. Difference in criteria for inclusion in the category of AML with CBPA mutation. In-frame BZIP in ICC, in WHO biallelic or single BZIP mutation qualifies. Next, very briefly, I will talk about the two classifications in myelodysplastic/myeloproliferative neoplasms. They're largely similar between ICC and WHO. In both classifications, these require the presence of both myelodysplastic and myeloproliferative features. The entities included are similar, except that WHO, instead of calling something atypical, chronic myeloid leukemia, now calls it MDS-MPN with neutrophilia, but we're talking about the same thing. Also in the ICC classification, in the category of MDS-MPN NOS, they have introduced a provisional entity, MDS-MPN with isochrome 17q, which WHO does not. There are some significant differences between ICC and WHO for the MDS-MPN category, and one of them is that ICC requires the presence of both increased counts and cytopenia at diagnosis. ICC uses cytopenia as evidence of MDS component with less emphasis on dysplasia, whereas WHO does not have a requirement for cytopenia at diagnosis. WHO still emphasizes morphologic dysplasia as evidence of MDS component. And then there are differences in diagnostic criteria for CMML, which sometimes can create diagnostic challenges, but in the interest of time, I will not talk more about that. And the difference in criteria are, again, essentially related to requiring cytopenia at diagnosis or not, and whether dysplasia is important or not. The last category we'll very briefly talk about is myeloproliferative neoplasms. And this category is actually the least problematic between the two classifications. They're largely similar. There's similar diagnostic criteria. They're really very minor differences, and those differences are in chronic myeloid leukemia. ICC continues to recognize an accelerated phase. WHO does not, and WHO actually defines high-risk morphologic and genetic features within CML chronic phase. Essentially, they're saying the same thing, but just calling it different things. Chronic neutrophilic leukemia, which is really very rare in clinical practice, ICC has lowered the WBC threshold to 13,000 if you have an activating mutation in CSF3R who requires the same threshold of 25,000 regardless of whether you have this mutation or not. But really, it's clinically not that significant because these cases are rare. WHO includes juvenile myelomonocytic leukemia as MPN. ICC includes it under pediatric myeloid neoplasms. So again, not really that much different in the two classifications. So what are the implications of these two classifications for us? As we saw, now both classifications have an expanded list of entities. The diagnostic criteria are fairly complex and nuanced. Both pathologists and clinicians need to be familiar with both classifications. Genetic testing is not optional for most of these myeloid neoplasms. It is required for diagnosis, prognosis, and therapy. As a result, what has happened? There is a significant increase in genetic testing. There is also a need for standardization of testing and designing tests that include all relevant genetic abnormalities. Now that we've added so many to the list, if we continue to use the tests that we had earlier, they may not cover all the abnormalities that we need now for our diagnosis. Also, a requirement for better turnaround time. I said rapid, but rapid is relative. But we can't wait for, let's say, 4 weeks, 6 weeks for these results to come back because they do impact treatment and also treatment upfront. So there is a need for us to change our turnaround time for this testing. What about the discordance between ICC and WHO? What does it mean for us? Well, for pathologists, for one, we should include diagnosis according to both classifications in our reports, particularly when the diagnosis is different. We need to include information about cytogenetics, molecular, and pertinent morphologic and clinical findings in the report because sometimes, even if we just put just the diagnosis out there, and if, let's say, the clinician follows one particular classification system, it is helpful to know what else is there, what else might be clinically significant. Also, when the diagnoses are discordant, it is helpful to include in the comment what is different between why is it this diagnosis by one classification and not the other. So it's definitely a lot more work for the pathologists. What about clinical trials? When we design trials, it is important to include criteria according to both, or at least state what criteria we are using and not just the diagnosis, because the diagnosis may differ based on what criteria you use. What about the treating clinicians? And as we saw in all those examples that I had, they need to look at treatment options based on diagnosis from both ICC and WHO, and then decide what would be the most appropriate for the patient. Where are we going in the future? Well, while we have all these differences allow us to look more closely at our classification criteria. Over the next few years, we can refine our diagnostic, prognostic, and therapeutic algorithms based on our experience using the two classifications, based on further advances in our understanding of genetics, and more collaboration between the pathologists, treating clinicians, and diagnostic labs. And the hope is that with all of these, we will have more evidence-based guidelines resulting in a unified classification. At least that is our hope. I included a few useful references here. Many of these actually are recent studies that are already evaluating the two classification systems to determine if the criteria are valid, should they be changed or not. And with that, I will end my part, and thank you so much for paying attention on this rather dense and complicated topic, and I'm happy to take any questions.
Yeah, thank you for walking us through that. Really appreciate that. So yeah, we'll dive into the Q&A. People are still free to add questions as they have them. The first question that we have is one of clarification. Someone asked, did you say that MDS with complex karyotype is not associated with poor risk?
No, that's not true. It is. But I think when you have MDS with complex karyotype, um, definitely it is poor risk. So I think, is the comment more like how we would classify that? I mean, it certainly is associated with the poor risk. I'm not sure what.
I think they're just looking for clarification to make sure that they heard correctly. And if needed, the person that put in that question, feel free to enter a follow-up question as well to go off of that for sure. All right. So the next question we'll have is, I know you mentioned this a little bit with the writing of reports, but how do these classification systems impact interdisciplinary communication between lab professionals, hematologists, and oncologists?
Well, for one, our communication has definitely increased in terms of, for let's say when we look at between pathologists and treating clinicians. First of all, I think starting with testing. When we get a case for a certain diagnosis, the first thing is, are all the tests, whatever is needed, is it really ordered? And like pathologists and clinicians need to discuss that. Well, whatever we need for testing, is it there? Once you've made your diagnosis, when you have these discordant diagnoses by WHO and ICC, oftentimes we end up discussing with the clinicians, what does it mean? Why do we have this discordance? And then the other thing is expected turnaround times. We have these classifications. Clinicians need all that information, and they're like, well, I needed to treat my patient. And you're like, well, I don't know, but you need to wait. I can't give it. It's not how it used to be. Well, this is AML. I have the FISH results, and you can treat. And they're like, well, I need NGS. So I think it's communicating the expected turnaround times. So it's both pre-test, ordering the right things, once you have discrepant diagnosis, communicating with them, also setting expectations for turnaround time. And then I kind of feel like pathologists and also the diagnostic labs, we have a lot more communication in terms of when we get the results, like some of, let's say, AML with mutated CBPA, it's like, well, what does it mean? What kind of mutation is it? As pathologists, we are not that familiar with molecular diagnostics as people signing out those cases. And they are not familiar with the nuances in our classification. So it has resulted in a lot of back and forth and everybody trying to understand the two classifications. Does that answer your?
Yeah, no, thank you. And following on with that is, so what strategies can labs use to educate clinicians on the implications of the classification differences for diagnosis and treatment? Have you found any strategies that you've implemented, whether it's, just during tumor boards or anything like that, or, equivalents for whatever you guys are going through?
Yes, I think one of those, what you're doing now, having these webinars, having these conferences on a, broader scale within the institution. When we have tumor boards, when we have interdisciplinary conferences, we actually talk at length about what has changed. And even, cases that were previously called something, now they would be called something else. There is a lot of discussion between the two groups. Small presentations, even if it is 10 minutes, 15 minutes, it's hard for people to find time when you have a relevant case. Just giving a really short overview, short summary of what is different, what has changed is helpful. Another thing is in our reports, as I mentioned, explaining a few things in the comments is helpful. From the lab, when we get the lab reports, I think it is very helpful when they add something. Like, what is this mutation? What does it mean, based on the current classification? So for example, sometimes when we get some results back, if there are TP53 mutations or something, there is a comment saying that, well, there are two separate mutations and this would qualify as biallelic TP53 and it has significance in both classifications. Just those little things like that, just making minor changes like that has been helpful. I think anything that we try and implement on a very big scale doesn't work, but all these little things have made a difference for us.
Oh, it's fantastic. Thank you for that insight. I'm going to see. So going back, so we're going to take a step back to the question about MDS. So the person said, my question was regarding the MDS with TP53 mutation, the ICC versus the WHO. So they just wanted to check if the presence of a complex karyotype should qualify a poor risk regardless of the TP53 status per ICC.
No, so I think so. I understand. Okay, so I should have explained it a little better. So in ICC, if you have a case of MDS and you have a single TP53 mutation, in those cases, in addition to the single TP53 mutation, if you also have a complex karyotype, ICC says that you can use that complex karyotype as presumptive evidence that there is the second TP53 allele is also inactivated. So this is only if you already have a single TP53 mutation. Whereas WHO says that you cannot use complex karyotype as presumptive evidence, you have to demonstrate that that is inactivated by either deletion 17p or loss of heterozygosity on that locus. Did that answer the question?
Yeah, thank you. Thank you for the clarification and for chiming in there again. Thank you very much. So the next question we'll have, I think we have time for one or two more, is how can labs ensure consistency in longitudinal patient data when classification criteria change over time?
It is very hard, very challenging. And that is something, whether you have one classification or two classifications, as we saw, classifications will change over time. And I think the more important thing is, when we have our reports, when we have our diagnosis, that is why it is essential. It's not just the top diagnostic line. It is actually including all the pertinent information. It is making sure that we meticulously include all the information, document it, and then as criteria change, you know that what was previously classified as one thing, what it would be classified as now. It is hard to keep track of everything, but I think we have no other option. So it's the way I look at it is, instead of merely focusing on the top line, the rest of the information that we provide, whether it is as synoptics or whatever, or as addenda, whichever way, that is extremely important.
Awesome. Well, it looks like we are about up on time. So thank you again for taking the time to speak with us, getting into some of the weeds on this topic. I know it's obviously a big thing to handle. We appreciate you taking the time. Thank you to everyone that watched the webinar, who spent the time with us. Hope to keep you in mind when you got more webinars coming up. Stay tuned in for in the future anything that comes up. Welcome you to sign up for DXRX, and yeah, thank you for the time. We hope everyone has a great rest of the day.
Thank you.